My name is Casey Hersch. I'm a licensed clinical social worker, author, and founder of LightYourSparkle.life. Today, I'm here with Dr. Jeff Lackner. He is a professor of medicine and chief of the Division of Behavioral Medicine of University at Buffalo. A unique feature of its clinical services is the use of evidence-based treatment protocols that help patients gain control of symptoms that have not adequately responded to standard medical therapies. His research focuses on developing and testing novel and safe treatments for chronic pain disorders, understanding their active ingredients, and identifying patients for whom they are most effective, and of course, their real-world value. With National Institutes of Health support since 1999, Dr. Lackner's research has influenced clinical practice guidelines and established him as an internationally recognized authority in the behavioral treatment of chronic pain disorders, particularly irritable bowel syndrome. His clinical work emphasizes a collaborative approach that recognizes that each patient is unique, which I love, and presents with specific problems and not simply a diagnosis or set of symptoms. Let's get started. Hello, Dr. Lackner. Thank you for taking the time to meet with me. Before we get started, I'd like to take a moment to share with you why I reached out to you. I am a licensed clinical social worker and a patient who lives with Crohn's disease, complicated by many years of childhood trauma, childhood illness, and excessive antibiotic use. Despite my professional background in mental health, no one, not even my own field, validated the connections between my physical and mental health. Several years ago, I wrote a book using my life as a case study to not only demonstrate the psychosocial influences that contributed to my disease progression, but to also credit the psychosocial assets that contributed to my resilience and survival. I don't want to see people suffer as I have, and sadly, not too long ago, I was still unaware of how my fears, adverse childhood experiences, and anxious thoughts contributed to my symptoms. Today, I want to unpack some of your research, as well as point people in the right direction so they can connect the dots of their own lives and bodies and expand their healing from the inside out. So let's get started.
Great.
In a recent article I read in Dr. Emran Meyer's Mind-Gut Connection newsletter, you state that research suggests patients with irritable bowel syndrome have a rigid mindset that likely disrupts the brain-gut interactions and generates debilitating GI symptoms. You also say there's good news because our mindset can be unlearned quickly, which can produce enduring symptom relief unparalleled by other medical therapies. Can you explain what you mean by this statement?
Well, there's a lot to unpack there. So let me just step back. So we know that IBS is a really complicated problem that's influenced by a variety of biological factors and behavioral factors, environmental factors, and psychosocial factors. So our research has been focused on psychosocial factors. And within that kind of box, there are a lot of different psychosocial factors. There are, as you said earlier, developmental factors, early child adversity, emotions, beliefs, how we react, our learning history. So there's a ton of different factors, and each of those things play a role in how patients experience symptoms and how they respond to symptoms. Our research has focused on how people process information about their environment, and how IBS patients process information about their environment. And I think in the article that you referenced, what we have found based on both our research and other people's research is that what's really important is not so much what people are thinking, what IBS people are thinking, but it's kind of how they're thinking. And, I think that we know that that the flexibility of how people think oftentimes makes it easier to respond to challenges. And that's complicated in people who have more severe IBS because their thinking style is characterized by a couple different factors. One is they tend to worry intensely. And by worry can be really helpful, but sometimes if it just kind of is excessive and uncontrollable and doesn't lead anywhere, it can kind of take life of its own and can come back to really haunt us physically and emotionally. Now, when we talk about worry, what we're talking about is this kind of tendency to kind of think the worst, jump to conclusions, and the other is to kind of, so that's kind of like what if thinking, but also ruminate when bad stuff happens, kind of like if only I had done this, if only I'd done that. So that's one kind of rigid way of thinking. Another are kind of core beliefs of perfectionism. They can be really helpful when they are a means to an end, but when they're an end in itself, that's another kind of way of kind of thinking rigidly. There's also a tendency to kind of spend a lot of time in your head and kind of what kind of social psychologists and cognitive psychologists call self-immersive thinking. And, you know, that's that as opposed to kind of stepping back and seeing things in a broader perspective. So those are kind of the different aspects of a thinking style that together make for a kind of a rigid way of thinking. Does that answer your question?
Yeah, that is really helpful. And yes, I can relate in ways I can't even express. I think that those of us who struggle with these functional gastrointestinal disorders tend to have a relationship with exactly as you described. Just we know it about ourselves, but it's not usually incorporated into treatment.
Right. So I think that what the article that you talked about that we wrote with Dr. Mayer and his group, my team and his group, why that's important is that, you know, I think a lot of the work in this area is kind of focused on what people think, you know, the thoughts, you know, it's when I feel abdominal pain, I feel it's terrible, you know, the kind of pain catastrophizing. And I think those constructs are helpful in describing the thinking patterns that patients have. They're not really helpful in understanding why treatments work or how they can work. I think the more robust treatments seem to be better at getting people to change how they think, as opposed to kind of the changing the content of what people think.
Yeah, and that makes sense to me just intuitively and also as a patient and also as a therapist, because when you focus too much on the content, if you're already of that personality type that tends to be more obsessive and can really ruminate, then you sort of start ruminating about the content and you don't, and the cycle almost gets more deeply embedded, is at least my experience, where
right. And I think that's a really, I'm sorry to interrupt you.
Yeah. Rather than like stepping outside of it and being able to look in it. And first of all, your work is the first, and I only learned about you just, you know, in my relationship with Dr. Meyer. Your work is the first time I've really seen anybody talking about this. And when I read the Mind Gut Connection newsletter and I saw that statement, it was so profound to me, because to me, I know you said there's a lot to unpack in it, but it calls out the fact, I think those of us who deal with these gut issues, we know there's a connection between the way that we think and that like hardcore, like perfectionism. But at the same time, you know, that reality that there is neuroplasticity and that the mind is capable of unlearning things, to me, that's the second piece that's empowering. Now, the question is how to do that. But the fact that your research is saying that and you're witnessing that, that is so important for us to hear, because we've been told our whole lives, pretty much especially in my case with inflammatory bowel disease, which I believe still has a component of IBS, but nonetheless, you've been told your whole life that you're just going to have to live with this. It's either going to get worse.
Right.
There's not a whole lot of hope when you unpack it as a patient, really.
Right. Well, I think if you focus on the content of what people think, you're always challenging specific situations. If you focus on how people think, then they develop a skill that cuts across situations.
Mm-hmm.
So it seems that would be helpful is if you teach somebody who's prone towards worrying, that when they enter certain situations, whether it's a new restaurant where they don't know the bathroom, or a new doctor they've never seen before, they know that in those situations, that uncertainty potentiates certain thinking errors that then kind of flares them up. They don't have to learn, specific, situation specific counters, because the counter cuts across the different situations.
Right.
So I think it's, as you said, I think that's a much more empowering, think about this. If you could think about an analogy. I mean, I'm wearing lace-up shoes today, right? And I don't have to, when I was 5, learn how to tie every lace up in a different way. I learned the kind of process, and that generalized different shoes that carries me over for the next 55 years. And I think the same thing's true with cognitive strategies, is that you learn how you think in different situations that are your Achilles heel, and that has a much more powerful way than just traditional CBT for pain disorders, which is, example would be, I have abdominal pain, therefore I have cancer.
Mm-hmm.
And the counter would be, I don't have cancer. I'm not sure that's a very convincing strategy.
Yeah.
Does that make sense what I'm saying?
It does. And that from 0 to 100, my husband, until I married my husband, it was not really, I think, I didn't necessarily understand that I had these errors in my thinking. It's like, I think even as a therapist, it doesn't really matter. You still kind of, when you're in your own head, it's sometimes hard to really, understand that there are certain ways of thinking that are a problem. And then
But
when
we all have errors in our thinking.
We all have these errors, right?
I mean, I was late because I forgot that you sent a Zoom, and so I started kind of yelling at myself and saying, and my focus was on not, okay, where do I need to get but on what I did wrong.
Yeah.
I mean, that's now, fortunately, when I have that error in my thinking, it doesn't flare me up in my gut.
Yep.
But we all have these errors.
Yeah.
We're not robots. We make errors all the time in how we think. And that's good, because we need that kind of efficient way of processing information so that we can work efficiently.
Right.
So there's no shame in thinking really fast.
Right.
And inaccurately, because it gets us, we don't have to put a lot of thought into driving or riding a bike or, making biscuits or, but sometimes that thinking gets us in trouble. The efficiency that gets us in trouble. And for some people, it literally gets under their skin.
Yeah.
Now, for you, it gets in that you feel in your gut. For other people, it's their back. Other people, it's headaches.
Very true.
Other people's chest pain. But it's not like it's unique. It's just that when some people do that, they pay a price.
Yeah, without question. And I, in the last probably just 10 years, with more people coming out and talking about the connection between adverse childhood experiences and trauma and how it really does affect the way that the immune system reacts and how the diseases can form. There is no question in my mind. And when I wrote my own book, this is what I set out to do. I had, a chronology that my mom had collected from birth. I'm an only child, had a lot of attention on me growing up. And so she had kept a date book of all the episodes of illness. And I, went back to that in my early 40s. And I started doing this like spreadsheet of all of this data and every antibiotic I took and this, that, and the other. And it was so abundantly clear that, for example, migraines was right when I was my parents were going through a terrible divorce. And then there was an episode of anorexia also during another really traumatic, time in my family life. So now that I'm aware much more of that connection, I feel like, the way that my thinking is wired and that fear-based response is also something that was deeply programmed in me in my early life. I am 100% safe now. I have a great life. I have a loving husband, great cats, and I'm so stable, but there is still this sort of catastrophizing and this belief that, something bad's going to happen. These types of thinking processes happen very automatic. And I'm wondering, that just seems like it's so much more complex when you've got these layers of trauma, and then you add that there's, inflammatory bowel disease and gut stuff going on. You almost have to get some help to work on those errors in thinking, because it can take me out very fast, and it does.
Well,
and it has.
I think you put your finger on, I think that those and for a variety of reasons, I don't want to minimize the impact of trauma, but I think I think your comment unwittingly suggests that it's much more complex, because I think that the trauma is one thing, but it's how the imprint that it leaves in people's ability to process information. For some people, that really kind of causes some negatively skewed ways of thinking about stuff.
Yeah.
For other people, it doesn't, and it seems like if you focus on some of those information processing styles, then that creates opportunities for intervening that you don't have if you just see it as the force behind it as trauma per se. Because the reality is that there are a lot of people that go through trauma, and it's not necessarily a insidious process.
Very true. Very
for
true.
some people, it can be a growth experience, and for some people, a mixed bag. So how do you explain that? I think you did a really nice job of kind of saying, well, one way that you didn't say this, but that's what I hear you saying, is that you take the trauma and you kind of, for those people who really kind of pay a price cognitively in how they think, that really led to some real bad outcomes. And by extension, when you had a shift in your life, your information processing style changed.
Yes.
You didn't, the trauma didn't change. You still, but where there's room for change is in how we relate to those thoughts and how we process those thoughts. That's what I think. But,
yeah, I love this. Yeah, it's so fascinating to me because you're right. Not everybody that goes through, I consider myself very resilient. I mean, when I look at my life and I see what I've gone through, there is definitely something in the way that I look at my environment and I have perspective that allows me to shift pretty quickly and to reframe something into something very positive. Like for me, not deny it, but to look at the things that are in my life as a result. And that has, and then also to maintain hope that nothing is stuck forever. Nothing is ever forever. There's always these things that come into your life that can help, these psychosocial influences. Like you talk, yeah.
So I think you're actually, I mean, I think you're very eloquent about this. I think when you talk about resilience, you know, you know, that's a very hot topic. You know, and some people will think of resilience as mindfulness or the ability to relax. And I think if I hear you, when I hear you say that, I mean, you captured a lot of the constructs that we see as fundamental to resilience. So I'll just give you a couple, because I think you're going to ask, well, how do you target, you know, how do you change? I mean, I do think that if we see kind of worry as two types, one is this tendency to think the worst, and this other about future events, and the other is this tendency to kind of catastrophize about bad events that have already happened. And so a resilient mindset, I think, if you kind of break down someone who's been through what you've been through and then kind of bounce back. And what does bouncing back mean? Okay. Does that mean you're mindful? I don't think so.
No.
I think what it means is, as you said, it's the ability to kind of experience adversity, see it as kind of time limited, that there's a beginning and an end. I think there's also this tendency to differentiate the emotional unpleasantness of an event versus how well you can cope with an event. I think the more the people who are resilient are more likely to kind of disentangle those two things.
Right.
So, for example, you know, when have you ever lost someone close to you?
Yeah, definitely.
Who's that?
Recently, just at Christmas, my grandmother.
Right. So that's a distressing, very distressing situation, right? Now, at the same time, people who are able to kind of bounce back are able to kind of differentiate their level of distress about that versus how well they can cope with it.
Right.
Right.
Definitely.
So they're able to kind of, you know, distinguish those two things. I think that it's more of a challenge when our emotional experience is kind of entwined with our sense of ability to cope.
Yeah.
I think that I think resilient people are able to kind of say, listen, this really sucks. It's really painful. But I'll cope and I'll cope.
Yeah.
So I think time limited, I think differentiating how distressing something, how upsetting something is, and the ability to cope with something. I think one of the skills that we teach our patients is this concept of adopting the so what approach. Not so what as if you're minimizing something. So it's not like, so what, your grandmother died because you have another grandmother. That's not the goal. The goal is, okay, so what would be the worst thing that would happen if my grandmother died?
Yeah.
Well, that would be really, really bad, right? You counted on her, you loved her, you spent, you know, holidays with her. It would be really hurt, you know, it'd be really painful. You'd miss her. But if you're adopting a kind of a different mindset, you're also saying, well, listen, I do know that's time limited, right? There's a beginning and an end. It might be out to 2 years, but there is a beginning and end. It would be upsetting and I could cope with it. And I guess the other thing we try to teach our patients is understand that the goal of cognitive process, content, whatever, cognitive um, activity is really designed to help us solve problems.
Mm-hmm.
Now, people who spend a lot of time in our head, like me and you, we lose sight of that. So if we're not doing something, we are thinking. But that's not the goal of mentation or thought. The goal really is to try to help us solve problems. So whether you think about your, about how bad it is with your grandmother, I mean, that is, at some point we have to kind of ask ourselves, at what point is that useful or not?
Right.
That's not to be dismissive of the memory of your grandmother.
Yeah.
But you want to be able to kind of rein that in order to make better use of thought when it's helpful for you.
Absolutely.
Does that make sense?
It does. Yeah. And I completely agree with that. It's, I know that staying stuck in these unproductive ways of thinking and getting into that rumination doesn't do anything but make the hole bigger and makes life that much harder. So I like to find ways to start to shift, as I call shift my energy, to get out of it. And the only way to do that is to look back at it and realize, okay, that's a part of life. It was really painful. I still have the memories. I still, do these little ceremonies, in my home, pull out a lovely quilt that she made, put it on the bed, remember those things, like do things to kind of keep the attachment close. And then also to have like a bigger, more spiritual, I think is also really helpful for me in that the bigger picture of life, that this is this process of life that happens, and, being in the moment more so.
I mean, I think that's a really excellent point. I think that, I don't want to hijack your agenda here.
No, you're good. You're not
hijacking. I think that, if we kind of see the problem with a rigid way of thinking is worry, intense worry, that's really hard, hard to control, then you ask yourself, why is it hard to control? Why is it kind of, self-perpetuating? And I think that for many people that we see, and for many people, many of us, that one of the things that happens is that we see people who worry about things that never happen.
Yeah, naturally.
Okay, so the person who has IBS, who worries that they're going to have an accident, that is a really legitimate concern, but it's a fairly low probability thing. Well, so the worrying about something that is low probability, it then becomes a source of relief that reinforces the worry. So the person actually at some point counts on the worry for the relief, and that is kind of a cycle that you don't want to go down.
Yes.
And that's not constructive.
Right.
So I think that, we try to teach our patients to worry constructively about things where they can generate a solution.
Yes.
But for those things that about the past and the future, where worry is used because it's the only lever they have for controlling, that's not really helpful.
Mm-hmm.
So if I'm worried that, geez, I really am going to not make my appointment at 6:30, that's not helpful, because I've already said to you that it's 6:10. So for me to think about that is not constructive.
Right.
And so I think when people worry a lot, it's hard to kind of know what good worry is and bad worry.
Definitely.
And I think we do see people who make quick gains when they just kind of say, I never really thought about that. It's kind of like, I always have worried.
Yeah.
And I've always treated every concern, the same. It's kind of like leaving, I don't know what kind of house you have. I live in a very old house with the stairs, and every once in a while, one of us will leave something on the stairs long enough for it just to become part of the stairs. And it just becomes, you walk past it, no one puts it away. It just becomes part of what's on the stairs. And I think that's part of worry when it becomes habitual.
Yeah.
When it becomes habitual, because it's reinforced.
Right.
And the goal, and the good news is that it becomes reinforced, it's learned, and conversely, it can be unlearned.
Uh-huh.
And it can be unlearned fairly quickly.
Yeah.
Is that helpful?
Yeah, definitely. And it goes to, there are two things. First, I want to talk about cognitive behavioral therapy, which is, of course, one of the techniques that we're talking about here. And then I also want to take some time and talk about breathing. So cognitive behavioral therapy, I have a mixed relationship with it, because in my training, it was something that you learned kind of as an adjunct therapy. And so as a therapist, you would always say, oh yeah, I'm trained in CBT. The reality, however, is that that model kind of gave people the idea that if you just change your thoughts, you change your life. And, I know many therapists who say they do CBT, but would not have a clue how to work with functional gastrointestinal disorder or IBS. So in my mind, there is a particular type of CBT that people should be looking for when they are dealing with something like Crohn's disease. And I don't know where that is and how to find that, but I certainly would love to, number one. And can you explain, where people should be looking and what they should be looking for if they are dealing with these issues and want to, just find out how to unlearn what you're talking about?
Right. Well, I mean, I think what we've been talking about so far has been principles of CBT, right? I mean, we just haven't talked about it as CBT. I mean, the idea of CBT is that our reactions are mediated or influenced by the way we think about stuff.
Mm-hmm.
I mean, you didn't say, when you talked about your history growing up, you said, well, from a CBT perspective, but you talked about how thoughts, how those experiences influence your thoughts.
Definitely.
I think CBT, when it's done well, can distill that. So certain things that you think about, whether it's being more vigilant or more attentive to threat, or more likely to worry across the board, and to kind of develop strategies for kind of unlearning that.
Mm-hmm.
I think CBT, it's probably the most robust treatment for IBS across the board, based on our work and some of the work that's been done in the UK. I mean, that's I think a function of both the efficacy of what we do and the disappointing track record of other treatments, of medical treatment. But so I think that any technique can be delivered in a very kind of mechanical way. When I see patients, I try to have this type of conversation so it doesn't seem too sterile. Mm-hmm. But CBT should be taught as something you're learning. You're learning a skill. It should be taught like so. If you go to a class, it should be the same type of way of learning something. Yeah. You're learning how to change your thoughts. You're learning how to change your behaviors. You're learning how to think differently. I think that one of the problems with CBT when it's taught is that it's way too complex. Right. And it's like, it reminds me of a cheap tour to Europe sometimes. Like it's Tuesday, we're in Italy. If it's Wednesday, we're in, France. And it's like every week people are taught a new skill that has no rhyme or reason. And so I think people just, like, that's not how people kind of learn. I think one of the good things I'm proud of with our protocol is that you're learning a cohesive group of skills that kind of flow from one another. So let me give you an example. Can I give you an example?
Yeah, thank you, please.
So let's say we take an example of someone who worries. You know, so you learn strategies for worry control. Okay, so you learn how to look at evidence and come up with evidence for whether the outcome that you expect is going to happen or not going to happen. Okay, and then you learn another type of worry, which is this kind of decatastrophizing, using skills like, is this time limited? Is there a difference between how distressing something is versus whether I can cope with it? And that kind of sets the stage for what and this is the other rich thinking that I forgot to add, is flexible problem solving. And the goal of flexible problem solving is to develop a better strategy for solving problems. Sometimes you want to solve problems, but other times you need to be able to kind of know how to handle the emotional fallout. So in our protocol, that strategy draws upon the previous skills.
That makes sense. Yeah.
Whereas I think a lot of times CBT, it's like, okay, we're going to do assertiveness training, we're going to do expressive writing,
Yes,
relaxation training, we're going to do communication, you know, and there's not a real cohesive, efficient way of skills building. And that can be really frustrating for a patient. And I think it's obviously when a patient struggles, I think it can be frustrating for a provider.
right.
And I think the proof is in the pudding, because we only, for one of our treatments, it's only 4 sessions. So that's like just 4 sessions. It's not a lot of time. You and I will spend an hour together. That's 3 more hours, and that's all we have together. So I think we have to be very efficient. And one way you're efficient is by thinking, how do you kind of put together a treatment that kind of, you know, kind of introduces a skill, builds a skill, introduces another skill that then kind of builds, you know, strengthens the previous skill. I think simplicity is really important. Does that make sense?
Yeah, and that does explain the lens by which I've looked at CBT amongst my colleagues and in my own training. It is something that you kind of scatter in here and there, but you're also doing it along with maybe solution focused techniques and maybe some Gestalt therapy, whatever your platform is. But it doesn't reinforce the times before. And so unless you're someone that just holds on to that one piece of CBT that you got in a session and you just kind of keep doing it over and over in yourself, nothing builds on the other. So I that does clarify some of my.
I will send you an article that I wrote about a year ago called Cognitive Behavioral Therapy for IBS.
Thank you.
Skills versus pills.
Okay, so, excellent.
Because it was for gastroenterologists.
Yeah.
But I think CBT is hard to do. And I think it's easier to just kind of give someone a relaxation app. That's not a very difficult thing. Or to kind of teach someone how to do diaphragmatic breathing, hypnosis, and those can be very, very helpful. But I'm not sure that targets some of the kind of thinking styles that kind of disrupt the brain-gut connection.
I agree.
And I think that's a challenge. And even when relaxation training is helpful, I think it probably works through a cognitive pathway. I think the research on this topic in the headache literature is that, you know, biofeedback and muscle relaxation probably work because they build confidence or self-efficacy. They don't work because you're really dampening physiological arousal. They work because people think, wow, I can change something that a week ago I thought was really beyond my reach.
Yeah.
So we do, and this segues into your other topic, we do teach relaxation training. Before we started getting our work, before we started our research, there was much more focus on progressive muscle relaxation training with IBS patients, or biofeedback, and we just said, let's do something fairly face valid, simple, easy to learn, and we focus on diaphragmatic breathing. People love it. They see athletes do it on a basketball, court, the free throw line, hockey goalies, dancers, tennis players, Lamaze, emphasis. It's part of life, and so it's easy to incorporate into life, and it's easy to learn.
Yeah.
What I think, does it really have a direct physiological impact? I'm not sure.
Okay.
I think that it probably has an indirect one by changing people's control beliefs.
Mm-hmm.
And people love it. People. I'll tell you a really funny story. In our recent trial, we had two conditions. One, a placebo, a psychological placebo condition, and where they received education and support, and the other, a CBT condition. And in the education support condition, there was no overlap with the technique. So they didn't get muscle relaxation training at all. They didn't get cognitive behavior therapy at all. At the very end, we're debriefing this patient about how they did. They said, I really liked it. I got better, blah, blah, blah. Like, what'd you like about it? I really liked the muscle relaxation. I was like, well, we didn't do muscle relaxation. Yeah, didn't we? I said, no, we actually didn't do it. Huh. And I think that she adopted because she felt more in control, and that she started, adopting other lifestyle changes that made her feel more in control. And that was one of the things she started doing. Mm-hmm. So I think it's a great exercise. It's not like the one we structure treatment around. I don't think there's any evidence that muscle relaxation training is a standalone treatment for these treatments. Okay. And I think you have to be careful if you're a provider, because it can be insulting. Like, just just learn to relax.
Right. That is such a sore spot for me. Because I've been in treatment, off and on throughout my whole life. I think that going to psychotherapy is really important. And I remember, even being in 7th and 8th grade and having my therapist tell me, okay, let's just relax more. And, it occurred to me probably, the last, 5 years, when I was doing something called sensory motor psychotherapy, which I really love because I'm a competitive ballroom dancer, and getting into my body and being able to have a good relationship with my body sensations really started to happen for me when I started doing ballroom dancing with these particular coaches that really know how to connect the mind and the body. But before that, breathing for me, people would just say, take a full breath. And sad to say, and I don't know how many people would agree with me, I'm not sure that I really truly know how to breathe properly in order to really support my mind-gut connection.
Right. Well, I think that most people, when they say that, would take a breath from their chest.
Right.
And then,
right.
I mean, that's not what you want to take a full breath from your diaphragm, using your diaphragm. So I think that there's a couple things you're saying. One is that it's kind of dismissive, just like take a deep breath.
Yeah.
And the other is that the prescription is wrong. Like handing someone, here, take these, and the medication's wrong. So to tell someone to take a deep breath, and then they take a deep breath, like, that's actually you could hyperventilate, which defeats the whole purpose. And I'm always amazed at how many people just learn that strategy wrong.
Right. It's very common. And like I say, in dancing, we talk about, how to do this more deeper diaphragmatic breathing, because it helps support the sport. And that's, what you need to do for a lot of reasons. But in terms of, day-to-day life, I tend to be one of these humans that I know that I shallow breathe. And I think there are times where, frankly, I might even like be holding my breath. And so I would be curious, Dr. Lackner, could you direct us to where someone might go to really understand how to do this breathing? Because I think it's important, even, several times throughout the day, whatever, to start really getting a concept of how to do this type of breathing.
I mean, I can send you some materials. Would that be helpful? I mean,
yeah, definitely. I would like to.
I mean, I don't think people need to make it complicated.
Right.
I mean, this is not like it's. I mean, I must have. I see at least 3 books on breathing.
Yes. Well, and there's another book that just came out that a lot of my physicians are promoting. My doctors.
The Anatomy of Breath.
Yeah, I think it's the one by James Nestor.
I know there's one
called Breathe. It's called Breathe. And
yeah, I mean, it's really. I mean, I love those books. There's one called Gut. There's one on Breathe. There's one on Salt. There's one on, I mean, I like those types of cultural books, but I think it's, listen, we were born breathing diaphragmatically. Do you have a dog or a child?
I have 2 cats.
So like all you need to see is your cat napping, and the cat is breathing diaphragmatically without the benefit of a very long book.
Yes.
Right?
Yes. Yeah.
So I think that, to learn how we get into bad habits and how we shift, the reason why we shift to chest breathing from diaphragmatic breathing is really helpful. But I don't think it requires the type of complicated process that we in our treatments, we probably spend in session 10 minutes on diaphragmatic breathing. The patients then practice it at home, and they do fine. So I will send you our worksheet.
Okay.
It's nothing very sexy.
Okay, well, I'm looking forward to it. And what I'm hearing you say is that the core of what you're talking about is really helping people create new patterns in the way that they're thinking. That by far is way more like what you've seen is more transformative in the big picture of how to support the mind-gut connection and help symptom reduction, with symptom reduction and pain.
Yeah, I mean,
just I sending someone home with diaphragmatic breathing.
Well, we do diaphragmatic breathing. I mean, I think, it's cognitive behavior therapy. So the thinking part is how the cognitive. And I do think there's a role for the behavior part, which is how we respond, how we react. So I think that's an important piece. But even that behavior part, even the relaxation part, what we call somatic control exercise, diaphragmatic breathing, there's there's going to be both a mechanical piece, which is how you're breathing diaphragmatically, but there's also going to be like an attentional piece, which is, are you so it's hard to get away with around all this stuff. Is there's a cognitive piece to it, even in the kind of, you know, relaxation piece that we prescribe.
Right.
I think that the research, both, you know, the mechanistic research, the cognitive science research, and the outcome research argues that the cognitive piece is really important. It's how we think. These centralized pain disorders, whether we're talking about pelvic pain or IBS or non-specific back pain, TMJ, the person spends a lot of time in their head. And they're thinking about a lot of stuff. And it doesn't just stop there. The rest of your body reacts to that.
Yeah.
And so you want to kind of unlearn some of that.
Definitely.
So it's hard to kind of say, like, I know what you're getting at, like, well, his approach is cognitive, but that's because these are centralized pain. These are problems that the brain is a big player in.
Yeah.
That's, you know, no one knows that better than Dr. Meyer's work and his group.
Right. Yeah.
It's hard to it's hard to treat these people unless you respect the role the brain has and mobilize its resources to unlearn some of what it's learned.
Yeah, agreed. Well, yeah, and conventional medical models focus on anything but that. You know, I mean, unless you get into more of an integrative model, you're focused on surgeries and lots of medication, and there isn't even really much of a discussion about lifestyle, stress, relationships, thoughts, you know, any of that, which is why when Dr. Meyer wrote his book, and, you know, I've spent some time with him, you know, his first book is basically just me just spread out on all the pages, which I love because it's not just one piece. It's such an integration. It's what you have in your life in terms of, you know, do you have extracurriculars? Do you have relationships? Do you have a time out in nature? What do you eat? I mean, there's just so many. And then how do you think? Are all these really important pieces, because we're not just one dimensional. We're very complex, and each person can package their own healing you know, package for themselves that will look very different from someone else's, but it's not going to just be one thing. If people really want to start getting better, it has to be, you know, in my case, it was ballroom dance, having a really good attached relationship with my husband, my pet companions, you know, having some music, and then being able to, you know, incorporate all those things, and then having just good people in my life who were able to give me unconditional positive regard. I see you, I get you. You know, these were very like basic things, but I would say beyond anything else that I've done, and why I'm still alive here today with all my organs, it's because I had those parts intact, and those pieces didn't come till later in life, but they were still there. So
that's very impressive.
The other thing I want to ask you about is self-administered cognitive behavioral therapy. So I know there's been some discussion, Dr. Myers mentioned it. Are there actually home-based treatment models that your patients are able to do?
Well, that was the focus of our grant.
Okay.
And then, you know, Dr. Meyer, that kind of led to a fair number of other treatments by other investigators, and including a digital therapeutic that Dr. Meyer's group is working on, called Mahana IBS, and that's work that is done with that's informed by a group from the United Kingdom, and they have it's a website-based treatment.
Okay.
It's kind of but I think those self-administered treatments are really effective. I think that there's something about less is more, learning skills, the
Mhm.
environment where you have symptoms, being able to attribute gains to what you're doing as opposed to what your doctor's doing, it's
Yeah.
very powerful.
Yeah.
I think it's the future. And that was before COVID. And now with COVID, I think they're even more important.
Well, and I think, Dr. Lackner, that's why I was so drawn to your work when I started unpacking it, because your model is really about the work you're researching, and what you talk about is really about helping the patients feel like they just have more control and empowerment in their lives. Now, before empowerment and resilience became like a fad kind of conversational word, I was back in the days when, in my early years of social work training, people didn't talk about empowerment and resilience like they do now.
Right.
So it means very different, it means something very different to me than kind of how it's been just
I'm not
spread
sure
out
we
all
know
over
what
the
it really
place.
it's.
And now I'm like, my husband's like, well, you say the word empowerment all the time, and so does everyone else. I'm like, I remember the days when we were, braving the terrain, trying to help our patients understand what it meant to
Right.
be in charge of their lives and to be able to, be active self-activators. So, but I feel like your work is teaching people and advocating for people to be able to have more control over what's going on. Because when you are going to a doctor and the doctor's telling you, especially in my case with Crohn's, I've heard many, many times from very, very high level specialists that it's not a matter of if you lose your organs, it's when. And, Casey, you have an incurable disease. So just, accept that the prognosis is not good. It's going to continue to get worse. And my early years of life, I was just sort of beaten down by that. And now it's like, I don't let that come in, because I'm in charge. And, yeah, there's genetics, life happens. We're not in charge of everything, but I do have a really strong role in my life. And patients need to hear that, especially if they've had embarrassing accidents and social situations, or all those things, that classic, going to take an exam and you have to go to the bathroom, and how are you going to leave your college exam, and and all those things we've all been through. But when you feel like you've got some ownership over it, the amount that the symptoms control you is so much less.
I agree.
Okay, well, I could go on and on with you. You can only imagine the pages of notes I had.
Well, we can make another appointment.
But we're gonna end it for today. Thank you.
This has been a delight, and let me know if there's anything I can do down the road. Okay.
Will do. Thank you, Dr.
All right.
Lackner.
Take care. Bye now.